while Atul gets ready with his presentation, a few questions to be asked. At what blood sugar level would you, is it acceptable to give intravitreal or periocular medications?
The AIOS has given us the level of 200 for cataract surgery as a random blood sugar. I think we can extrapolate that to the injections, and I think 200 up to 200 should be a safe level. This does not mean that if you are giving it at 2 or 240 or 250, it is wrong. But I think it is better that we stick to some guidelines and no specific guidelines for diabetes, for diabetic macular edemas. So I think we should stick to the guideline of 200. However, in exceptional circumstances, like if a patient has neovascular glaucoma, I think one can give it at 230, 240 also, but it is always advisable in diabetic macular edema that he controls the diabetes first and then we give him the injection.
Another question is that any special precautions for intravitreal injections in diabetics?
Other than taking care of the vascular pathologies, that is the CVA and the myocardial infarctions, one must be sure that the patient does not have any recent onset of ischemia or of any cardiovascular event. Other than that, no other specific precautions. One also should be careful that the patient does not have urinary tract infection or does not have an active wound on the foot. That is two more things which should keep into consideration. Because if you're going to take a patient with active infection in your OT and then do cataract surgery or retinal surgery afterwards in that same OT, then it is going to be very dangerous. That's something which we need to keep in mind. Atul, you are to share your slides.
Atul, once you are ready, we're just filling in.
Yeah, okay.
So some of the points were we had left out because you have incorporated them in your slides. Yeah.
So basically, this is not a presentation. It's just a series of slides which will act as a combination of a summary as well as a take sort of keep in mind before we close the this particular session. Just a few important points that I wanted to highlight. One is, of course, the importance of understanding the OCT. We all talk about OCT, we'll do this, we'll do that. But just like a glaucoma surgeon uses perimetry, it's very important that your OCT should be something which you can understand and interpret. So the most important one is here is you should see the quality of the OCT. So very often interpretations are made on very poor quality OCT. So just like you look at a perimetry in terms of the quality, in terms of false positives and false negatives, you should look at the signal strength. Then of course the grid that is made here, the reason why I'm showing you the Zeiss printout is because that's the commonest OCT machine that is being used. Of course there are many others, but this will just act as a sample guide because most of the others have kind of built upon what Zeiss has done. And of course, the important thing here is that you must see the location as well as the fundus picture. So that is again helpful. For example, as Ashish showed you, whether that was a diabetic macular edema or diabetic papillopathy, just by seeing where the scan is made, you can see which areas edema is. And of course, the grid that is made is based on the ETDRS pattern. And going here in terms of the values that you see, there are two things which are of importance. One is what is known as central foveal thickness. And central foveal thickness was used in the earlier. There was a question asked about time domain and spectral domain. So central foveal thickness was the thickness of the 6 lines which were used for doing time domain OCT, because it's a very slow scan. As compared to that, you have what is known as central subfield thickness. Now, it's important to understand the difference. Central subfield thickness is not the center of the intersecting lines, but the central subfield thickness is the central 1 millimeter. So it is the average thickness of the central 1 millimeter of the retina. Then of course, volume can also be used because these are the parameters which you're going to use to determine response to treatment. Then just going over again the points with regard to the severity of edema and the vision. Broadly divided into 3 categories. very little edema, good vision, medium edema, intermediate vision, and very bad edema. And very broadly speaking, in this category where you have good vision and very little edema, the important thing to keep in mind is that there is relatively less urgency. So you can take time to address the medical issues. So at this point, you need not immediately inject. You can actually go over the medical parameters and you have a sort of opportunity of correcting those before you decide on treatment. These are, of course, broad guidelines.
Can I just interrupt, Atul, one second?
Yeah.
Yeah, there was a protocol V which was there in the DRCR net. This protocol V took into consideration patients who had a vision which was better than 20/25. And they found that these patients did not change too much over a span of 2 years. So in many of these patients, one need not expose them to the additional risk of intravitreal injections or laser. One can just observe on this patient. This has been specifically addressed in the protocol V of the DRCR net. Thanks, Atul.
Yeah, that's exactly what I was saying, that you have time on your side.
Yeah.
So then you can observe them and address the systemic issues, medical issues. In the intermediate category, you're most likely looking at anti-VEGF injection as the first line of treatment. And in the more advanced category, then of course, almost inevitably, either it is going to be more anti-VEGFs or changing anti-VEGFs, or it may be an anti-VEGF with a steroid combination. So this becomes the more, you can call it like a combined treatment. This becomes more like a monotherapy. These are, of course, broad guidelines which one would look. So when you examine a patient, then you should look at these three kind of categories and try and place the patient. You can have patients who have DME with early PDR. In the sense that it is one injection treating both diseases. And often just the injection is sufficient. As compared to if you identify advanced PDR, here in fact injection is probably dangerous or contraindicated because it can produce sudden fibrosis, and that can cause a traction retinal detachment. So this is you must be able to differentiate between early PDR and advanced PDR, because in one, anti-VEGF injection is the way to go, and the other way, anti-VEGF injection is probably more dangerous. Then of course, sometimes you can have DME after doing a PRP. So the patient may first present with a PDR, and then you do a PRP, and then subsequent you have DME. Here, generally the protocol that is followed is again similar to a treatment naive situation. Then of course you have ischemic DME. There was a question asked about RAPD. RAPD will only develop if there is very extensive ischemia. But if there's just localized ischemia of the macula, there will probably not be any RAPD. It has been shown that in ischemic DME, anti-VEGF does help, but one would have to gauge the amount of ischemia, because sometimes it has been shown that anti-VEGF injection can even worsen the ischemia. So these situations, sometimes you may probably require to combine it with a focal laser. Then of course, for the general ophthalmologist, this is probably the most important sort of questions that they have, because almost everybody is doing cataract surgery with IOL. Just a few points with regard to timing. Again, just to emphasize what has been mentioned before, preferably do not operate in the presence of active DME. Active DME requires priority treatment first. Once that has been controlled, then in that situation, you can go ahead with the cataract surgery. In any case, most of the time, your cataract surgery is a planned surgery. The situation in which you may consider cataract surgery is where a patient has reached a sort of plateau where the edema has reduced but not going beyond a certain point. And those are the situations in which, as Vatsal said, or as some other persons also mentioned, that you can consider giving a combined. So if the patient has some residual kind of non-resolving edema, then if you are doing cataract surgery, you can top it up with some form of additional treatment. For axial leg measurement, you must keep in mind that uh, in a DME patient, in any case, IOL master is the preferred method as compared to doing uh, uh, conventional ultrasound biometry. As far as toric and multifocal IOLs is concerned, toric IOLs can probably be used, but you should ensure that the astigmatism is because of the cornea. And multifocal IOL, unfortunately, we do see as retina specialists a lot of patients who have history of diabetic retinal disease, and multifocal IOLs have been put. It's highly non-recommended because the quality of vision drops dramatically if a patient develops any form of macular pathology. So if a patient is, say, 75 years old, has 25 years of diabetes and no change at all, then yes, maybe you can consider. But if a patient does show early changes, then do the patient a favor and don't put a multifocal IOL. As far as YAG capsulotomy is concerned, the same principles. Always treat DME first. So if there is a patient who you've operated, had 6/6 vision, and has come after 6 months with a drop in vision, and you're not sure, then in that case, whether it is the PC haze or a macular problem, then better to do an OCT healthy and then go ahead with the YAG capsulotomy. And of course, post-op visual problems, again, the same situation what I mentioned is that how do you differentiate DME from CME? Uh, Often in the early stages of DME, the edema occurs in the inner nuclear layers, whereas you would see edema closer to the center of the fovea in conventional CME. And FFA can also be used because in FFA you will be able to identify leaking microaneurysms. So these are two broad categories which you can use to differentiate between the two. And it's important to differentiate because again, the treatment would be different. In one, steroids would be probably the first line of treatment, and in the other, you would use anti-VEGF. Then of course, now we do have the newer methods of doing imaging, and I'll just quickly highlight a little bit. One is of course your ultra wide field imaging, and that has been shown to be particularly useful because in some patients with recalcitrant edema, they've shown that peripheral ischemia, which is missed by conventional FFA, is responsible for the edema. And by doing laser to the periphery, the central DME has also improved. So this is something which you may want to consider in a patient who has recalcitrant edema. Of course, the other advantage of FFA, sometimes if you're not getting a good image, FFA always gives you an excellent image of the macula in situations like this, a patient with asteroid hyalosis. Then of course, just comparing fluorescein angiography with OCT angiography. OCT angiography has the biggest advantage of OCT angiography is that patient acceptance is very, very high. And you can repeat it as often as you would do an OCT in patients with DME. And here you can see a comparison of FFA on the left side and OCTA on the right side. And you can see the immediate advantages. The FFA is showing you the microaneurysms. Now, you can say, well, I can't see microaneurysms in OCTA, but in any case, if you're going to treat with anti-VEGF, then seeing or not seeing the microaneurysm doesn't make a difference. What is probably more important, as you can see here, is FFA will never show you the foveal avascular network and the perifoveal vessels as well as OCTA. So this kind of detail is supremely visible on OCT angiography, and this is useful, especially if you want to track changes in increase in size of the FAZ, especially if you're giving anti-VEGF. So in the era of anti-VEGF monotherapy, OCT angiography actually scores over fluorescein angiography. And of course, laser, again, as Ashish has covered, the indications are becoming lesser and lesser. So you would use it for extrafoveal leakage, where there is just locally a few points if you want to use the microaneurysms as a guideline. And again, patients with less than 500 microns, there's no hard and fast rule, But what it generally means is that if a patient has edema of 500, 600, 700, you're not going to go with laser because the amount of thermal energy that will dissipate will cause more damage to the photoreceptors. And of course, non-center involving, useful when you're combining it with anti-VEGF or with PRP or with visual text. So still, laser has a role, especially in our kind of Indian scenario where patients may not be able to afford too many anti-VEGF injections. And with regard to comparison, again, as has been mentioned, all of them are useful, but aflibercept probably at least one study shows that if the initial visual acuity was mild, then there's not much of a difference. But at worse levels of visual acuity, aflibercept probably has an advantage. This is, of course, one of the study's results. There are many others also. Then just answering a question, what happens if there's a delay? Again, this has been talked about by many, that sometimes the patient doesn't come up, or even after a diagnosis, he'll suddenly come up after 6 months. So basically, this chart shows what happened to a patient who waited for 6 months and then started treatment. Even this patient will improve. But as compared to a patient who has taken treatment right from the beginning, the amount of improvement will not be as much. So it's important to emphasize to the patient that if there's any delay, then to minimize the delay. That is, the patient cannot take treatment immediately, come after 1 month, come after 2 months. Don't delay it. And does prior treatment. Sometimes the patient says, I've already taken laser, do I need anti-VEGF? It has been shown that anti-VEGF is useful even if the patient has taken laser or some other modality of treatment. Again, just to summarize the medical management, these are again the list of tests which you can advise your patient. So don't just advise an OCT, you can order out some routine tests. Ashish has also mentioned vitamin D3 and vitamin B12 levels. Obstructive sleep apnea test is a very special test, not done at all places. I think Hinduja has and Jaslok also has. So you have to probably refer to a specialized center. All the other tests, of course, you can get it done at any laboratory. So that's just a kind of a summary as well as a kind of points to emphasize before we close this particular webinar.
Couple of comments. One, that for sleep apnea, it's just good to ask the patient, like this is how I approach the whole thing, because subjecting everybody to that proper sleep apnea study, it doesn't work out economically as well as practically. So the first question is, do you snore while, does the patient snore while sleeping? And that's the question. To invariably the patient will say, I don't snore. But then you have to tell him that you don't know whether you're snoring or not. So it's your attendant or wife or home people, the spouse, who will be able to answer that more correctly. The next question, if the person snores, is that does he snore, does he or she snore while lying down straight or also in the lateral positions? If it is in the lateral positions also, then most likely they would need some kind of sleep apnea evaluation. If suppose that is the answer is negative, then best thing is to tell them to sleep with the head a little elevated and sleep on the right or the left lateral position, and then observe. If the snoring stops in that position, most likely there's no severe obstructive sleep apnea. This is just a rule of thumb that I apply. Also on the net, there is a stop bang questionnaire. So there it grades your answers, and if it is beyond a critical limit, then those patients certainly do need a sleep apnea evaluation. The other independent comment that I had was that when you, before initiating treatment for DME, you correlate your clinical fundus findings along with the OCT findings. The more disorganization and disruption of various macular layers that you see, various retinal layers at the macula that you see, the poorer is going to be the ultimate visual outcome. And the more exudations towards or at the center, again, the visual outcome is going to be poorer. Now, the patient and the attendant needs to be warned about all these things. before one starts treatment, so that one is not because all these anti-VEGF treatments tend to be expensive, so one does not want to be at the end of the day, be questioned or blamed for the an outcome which the patient is not able to accept. Please, thank you.
Thank you so much. Yeah.
One point. There was a question which was asked by somebody, any role of injections in severe NPDR? I think injections are something which is an invasive procedure. They should not be taken lightly at all. If you have pure NPDR without diabetic macular edema, there is no role of injections. If you give the injection in a diabetic macular edema, it has been seen that the level of NPDR comes down, which means that you may have a very severe NPDR after giving 4 to 5 injections. It may come down to a moderate NPDR. So the level of NPDR may come down, but electively only for severe NPDR, injections do not have a role.
Yeah, that was a very nice point, practical point which you made, Ashish. So I think we've almost reaching up to 2 hours. There was a marathon session on diabetic macular edema, but we touched almost 220 participants today. It was a very common topic. We all see patients of diabetic macular edema. So I think Dr. Ashish, Dr. Ursekar, and Dr. Paridosh Kamdar sir gave us some very important and salient points about diabetic macular edema and how we can apply them in our clinical practice. I would like to thank all of them and all of the participants, all of the quiz winners also. Thank you so much. And I think for the next week's seminars, CMEs, online CMEs, we're going to formulate the program probably by tomorrow or day after and put it up on the WhatsApp group. So thank you everyone, and have a nice weekend. Sapnesh, you want to add something before we leave?
No, only somebody wanted to know the name of the questionnaire which Kamdar sir mentioned. The sleep apnea questionnaire name.
Is Dr. Kamdar sir there still?
Okay, I'll ask him and put it on the group.
Yeah,
thank you.
Please.
Yeah, thank you everybody.
Thank you everyone. Bye.
So with your permission, should I end the meeting?
Yeah, please go ahead. Please go ahead. Thank you.